Hey guys, so for today's video, I'm going to be talking about common Crohn's and ulcerative colitis medications. There are a number of them. I'm only going to do the prescription drugs rather than going into all of the vitamins and supplements. There are a number of vitamins and supplements that are used in conjunction with the medications I'll talk about, but I'm not going to go into those. I'd rather focus on the prescription ones and yeah. I know that I previously made a medication video, but I believe in it I talked about the medications that I had been on, and then I also had a friend, her name is Caitlin, she came on and talked about her medications as well, because we were both on different ones, but I don't think I made like kind of a list of medications that anybody could be on, so that's why I figured I would do this video. So the first drugs that I'm going to talk about are the anti-inflammatory drugs, and these are the ones that they usually start us off on to try and get us to remission as quickly as possible. So that usually includes the corticosteroids and the aminosalicylates, and there are a few of these that I have been on. I think probably almost everybody with IBD has wound up on a corticosteroid, something like prednisone or IV methylpred if you wind up hospitalized, and then they also have a newer one that has shown less side effects called Enacort. I can't remember what the generic name for it is, but I remember it as Enacort. It was something that I was on. Now the side effects with the corticosteroids you guys probably are well aware of: the moon face, the mood swings, the night sweats, irritability, osteoporosis, growth inhibition in children. That's why they don't like kids taking it all that long. There's just a lot of side effects, so they really don't want patients to take it for long periods of time. The reason that they put people on prednisone or another steroid is it really is effective. It's so effective, but it's just got so many bad side effects. So they'll get you on it, try and get you into remission while also introducing another drug to maintain the remission. So I was put on prednisone first. I remember it being a tablet and it was just awful tasting. I used to take it with like some kind of drink like orange juice, or I wouldn't take it with water because I couldn't take the taste. And then I was luckily able to transition off of that onto Enacort, which has less side effects. My moon face went away on Enacort, and I had no trouble between the transition from prednisone to Enacort, but I had a lot of trouble getting off of Enacort. My symptoms would just go through the roof every time that they tried to lower the dose, and that was the one that took me about 6 months to get off of. Also included in the anti-inflammatory drugs are the aminosalicylates. I'm sorry if I pronounce all this stuff wrong, because I just know it by like the trade name. But those include the mesalamines and the sulfasalazines. I totally hope I didn't butcher that. But stuff like Pentasa, Asacol, there's a number of them. I've taken Pentasa, and I tried to research. I remember being described its mechanism of action, but I also tried to look it up to kind of give you a better idea of what they do. And basically what I found was not helpful. They don't exactly know how these drugs work, but they seem to have an affinity for the intestinal walls as well as other tissues in the body, but for our use, intestinal walls. And they think it's more of a topical, kind of covers the intestinal wall and protects it. I don't know if there are any other purposes for this drug, any other uses, but that's basically what I found, and otherwise it just said online, unknown. But that's my GI doctor when I was first put on Pentasa. That's how she described it, was basically coating the walls to protect them. Another grouping of drugs that they sometimes use are PPIs, or proton pump inhibitors, basically used to decrease acid secretion in the stomach, particularly useful if you have disease active in your stomach. But these would include something like Nexium, Prevacid, Prilosec. I think there are a number of other ones, but those are the three that I've actually been on all three of them, but those are the three that are most commonly used. I usually see more of the Prevacid and Prilosec. I think that they're generic names are lansoprazole and omeprazole, but I do not see Nexium too often. We actually don't carry Nexium. Patients that use Nexium, that's something that they have to bring in from home and we get it approved. Nexium is so expensive. I remember it costing $4 a pill when I was taking it. So we're like, let's see if, you know, if Prilosec or Prevacid would work, and I noticed absolutely no difference between the three of them, but I did notice that that probably helped the most because I was having a lot of acid reflux, and that was probably the best thing that I got on board. I would wake up in the middle of the night with pain, just that burning feeling coming up my throat, and I have to sit up in bed and kind of breathe through it, and that decreased quite a bit once I got the proton pump inhibitor in my medication collection. The next set of drugs are the big ones, the big daddies. These are the immunosuppressants, and this is kind of what they want us to get on after a steroid. There's a number of immunosuppressants, which I've talked about some in the past, and some are newer and just approved for Crohn's disease, but they basically have, all of them have very similar side effects. It's basically just their route of administration that's different. So the first two that I will talk about are Imurin and mercaptopurine. Mercaptopurine was the only immunosuppressant I've ever been on. I was on it for 9 years, and I don't think that it helped me at all because I wound up getting resections and all this other, you know, I had symptoms all the time. I never really noticed too much of an improvement. So, but these are technically considered chemo drugs. They have similar side effects to chemo drugs used for cancers, I believe, but also used in IBD because they suppress the immune system so it doesn't attack your intestines. Your body thinks that your intestines are a foreign object, so we're kind of suppressing that action. We're telling our bodies to chill out, stop attacking itself. That's basically what immunosuppressants do. Unfortunately, with these drugs, they cause a number of side effects. I have heard that hair loss can happen when we take these for IBD. I never really experienced any hair loss with mercaptopurine, but it can happen. It can also cause liver and pancreas inflammation. When I first started on mercaptopurine, I had to get blood tests weekly to check my liver enzymes and all of that to make sure it was not causing any liver issues. Also checking the therapeutic levels to basically get me at a point where they knew the dose was right. So I remember my dad and I constantly having to cut the pill. It's a tablet, and we would cut it into halves or fourths, basically whatever the doctor told us to get the right dose. And I remember some days I'd take a full pill, and then the next day I'd take half, and then the next day I'd take a full. So it's you have to get a very exact dose with it. The next set of drugs are the TNF inhibitors, which I've talked about. Remicade in a few videos back, we talked about that. The tumor necrosis factor, it inhibits that. So Remicade is an infusion. It winds up being 2 to 3 hours long. There's also Cimzia, which is an injection, I believe, and then Humira, which is an injection. I'm not sure how often you get Cimzia typically. Humira, I think, is weekly. Another injection is methotrexate, also used in rheumatoid arthritis, Rheumotrex. I've never heard it called that. I've always called it methotrexate, but that's just another one of the immunosuppressors. There's also Entyvio, which I have given one time to one patient. It's one of those drugs, I think it's not quite as new as Stelara for Crohn's, but it's one of the newer ones, and they don't typically like to give it to children. You have to go through special approvals. There's a committee that decides whether or not you are eligible as a child to have Entyvio, because I've given it to a patient under the age of 18, and I remember kind of reading all the notes and seeing like, oh, they had to be specially approved for this. I love Entyvio though, because it is the easiest. It's like giving a normal, if you were to give an antibiotic through the IV. That's exactly what it's like. It was so nice compared to Remicade. I was like, whoo, quick. And basically what Entyvio does is it blocks these immune cells from binding to the intestinal wall. And the last one, which was the most recently, I believe, most recently approved drug for Crohn's disease, is Stelara. I know a lot of friends who have kind of reached the end of the road with drugs and there aren't too many options left, so they are trying to get approved for Stelara. And I know that the approval process with insurance has been difficult for some people, just what I've seen on Facebook and some of my friends. And I thought we had a patient trying to get Stelara, but it might have been Entyvio. But they are having difficulty. I don't think they give Stelara to kids under 18. It might be something similar like with the Entyvio, the whole committee deciding whether or not you can get it under the age of 18. But Stelara is pretty new for us. It was used for psoriasis first, and now it's used for us. It's FDA approved for us. Yay! And then the last two drugs that I'll talk about are like super common. I can't tell you how many times I've given them for IBD kids. Antibiotics are often used with Crohn's and colitis, particularly if they think the bacteria in your gut is harmful, if you've got kind of an overgrowth, or if you have an abscess or some kind of fistula, it's gotten infected, and they're just trying to treat it before they start doing other IBD drugs. They'll treat with antibiotics to try and take care of that, and the two that we always use are Flagyl and Cipro. Now, I was researching online and I was seeing things that Cipro is used more now than Flagyl. They prefer it over, but every time I've given one, I've given the other with it. We call it IV doubles, and that's what we do. We give Flagyl. I think Flagyl is usually every 6 to 8 hours, and then Cipro is every 12. And we just run those for a few days to try and take care of whatever's going on in the gut, and then we can continue treating the Crohn's. Now, sometimes the antibiotics have kind of a negative effect with IBD, because if you've ever taken an antibiotic and gotten diarrhea, you know, it's getting rid of your healthy bacteria too. So it's kind of a balancing act. And then Flagyl, if you didn't know, you cannot consume alcohol. You will get violently ill. Flagyl is actually a drug they use with alcoholics to try and deter them from drinking. So just something to note. Even stuff like mouthwash with alcohol in it, you're not supposed to use because it'll make you sick. Just a little piece of information for you. So I know that was a super quick super quick summary of IBD drugs. I didn't name every single one, like I didn't name all of the sulfasalazines, because there are some that I've never even heard of. I named the ones that I'm familiar with and I have given, or I've had friends take them, or I've taken them myself. Some of them I'm like, I've never seen anybody take those. Now, it's not saying that there aren't people who take them. Maybe the first, I think they have like the ones that they usually give, like Pentasa or the Asacol, and then if those don't work, they move on to different ones. But those are like the two that I've seen a lot of. But anyway, I think that this video was a good covering for somebody kind of starting off on the journey to see what medications they typically can get. So they usually start off with the prednisone, either IV or oral, depending on the severity of the disease. When you go in to get treatment, they'll go to oral immunosuppressants, and then from there they'll go on further to the IV infusions or the injections. Occasionally they will go straight to something like Remicade if the disease process is severe enough, like we haven't caught it early enough, just to try and get the hardest drug working fast, because I think that the oral, like the Imurin and the mercaptopurine, that takes months, like literally months to have an effect. So sometimes they get the Remicade on board, because I think typically, I've heard so many different time periods of working for Remicade. So I've had doctors say, you know, it works in a couple days, it works in a couple weeks, it works in a week. It just really depends on the patient, I think. I don't think there's any clear answer, but it seems to work quite a bit faster than the oral immunosuppressants, because mercaptopurine, I guess it had small effects on me, but it took months, if it even ever worked. But it took months to at least get used to the drug. It caused me a lot of nausea and vomiting. I remember it was a weekend because I started the drug on a Friday, and I got so sick. I was throwing up everywhere, and what we wound up doing is we cut the dose in half and kind of had to titrate up on the drug because my body couldn't handle the full dose that my doctor wanted me to take. Oh, it was bad. But then it took a couple weeks, and then my body got okay with it. But yeah, so that's our overview of IBD drugs. Very simple. If there's a certain drug that you would like more information on, let me know. I'll do my research. I will ask friends, and I can make a video on it. Alright guys, I will talk to you soon, okay? Bye.